I sent a message to those guys. Hopefully they'll jump on.
Okay, great. Yeah, there's probably going to be a few more to jump in. Real quick, just let everybody know this is our last call for the year, our last 50 vets call. Thanks for joining in. I think a lot of people have seen sort of the topics for 2023. I'll pull them up here real quick, and if you want to get a copy of this, if you haven't seen it, it'll be on the website and we'll pass it out. But the first meeting for next year will be January 31st. And really, we'll go over what the campaign's going to be about for the year. We'll talk about what's your number campaign. And we'll go over sort of the basics. We've tried to develop this to take people through through a journey of prostate cancer. And so really, we've also been asked by the head of the VA Community Care Network to early in the year talk about it, as well as a new program that we're looking at called Living with Advanced Prostate Cancer. And that's really living our life with ADT and trying to educate guys on what's going to happen when they do have metastatic disease or they're given start to have to live on an ADT regimen. We'll talk obviously about screening, biopsies, prostatectomies, radiation treatments, ablative type treatments. And then we'll really promote clinical trials, metastatic disease, chemotherapy in the late summer, and then get into some health IT. We're going to do 2 in September, as you can see, since it's Prostate Cancer Awareness Month. We'll talk about health IT and then also Prostate Cancer Awareness Month and all the details that go around there. Caregivers, November and November, we're looking at doing a men's health fair in San Diego during Veterans Day for next year. And then again, we'll end the year with DNA sequencing. So, and what's the importance of DNA. Just a quick update on the congressional front. I got a call from Congressman Dunn. They are, if you remember, HR 4880, the Veterans Prostate Cancer Treatment and Research Act. They've combined a little bit of money into it, and they are trying to push it into and redline it into what's called it's going to be a VA omnibus, which will have some additional money in there for us, and we're trying to pick up a little bit of that money as well. Anyway, so that's kind of the legislative front, and then that's about it for that whole thing. So Christina, I wanted to introduce Christina Nakamoto. She's the urology medical science liaison for Myriad Genetics. And I'm going to let you introduce yourself to the rest of your details, and then give us the talk about your timely products in oncology and with respect to prostate cancer.
Sure. So I joined Myriad May of last year. Prior to that, I'm a PA by training, and I worked in the surgical oncology space in breast, and then prior to that in the medical oncology space. And I was very familiar with ordering Myriad products. They were very relevant in both of those spaces. And so then I made the journey over here after I saw at the patient level the big impact that these products made for patients and their family members. And so as Mike said, I'm the medical science liaison for the urology unit over here at Myriad. And I'll go ahead and get started. And this is a presentation about both genomic testing in the prostate cancer space as well as germline testing. And I'm going to keep it just kind of basic. And if anybody has any questions, please stop me. I'd be happy to answer them. All right, I'm going to go ahead and share my screen.
And Christina, as a reminder, a couple of things with all of us that are on there, there's 5 of us on here that are actually volunteers that work with VAs. And so as we go through this, please, whatever foot stomp or tell us the messages that Myriad really wants us to portray or to take into some of the different VAs that we visit or that we're doing work with as well. Okay.
Okay. And I know from, and we can get to that kind of at the end too. I know from a VA perspective, I know that VA systems kind of decide what and who and where, they'll pay for testing. And so I don't really know. I know this is 50 vets in 50 states. I don't really know, specifically what, just, like an overarching theme in the VA, I know is sometimes like getting access to testing from a financial perspective can be difficult. So I'm not really, I don't know if Sophia can speak to that more than I can, but just in case any of those questions pop up, I can find the answer if y'all need it.
Sure. Thank you.
Okay. So I'll start out. Traditionally, prostate cancer has been treated based on patients' clinical features, pathologic features, meaning what is their Gleason score? What is their PSA? What is their tumor stage? What does their cancer feel like on their digital rectal exam? What does their imaging show? We've never really, prior to biomarker testing in prostate cancer coming on board, we've never really treated prostate cancer patients and their disease as individuals. It's really prostate cancer patients have been grouped into cohorts. And we've decided, if you have low risk disease, low volume disease, intermediate risk disease, high risk disease, we're going to treat you like this, because this is how we're going to treat this group of patients. However, we know that not all prostate cancer behaves the same. Some prostate cancer, even within a group, a risk group, is going to behave more aggressively, while others might behave more indolently. And so in a study done by a guy named Schreiber, last name Schreiber, the results of this study showed that biopsy Gleason scores and surgical Gleason scores, when reviewed by GU trained, so genitourinary trained pathologists, so they did an extra fellowship just to look at that type of tissue, they only agreed 55% of the time on what the Gleason score was. So that's a little concerning, because we're relying on these pathology reports and Gleason scores to tell us how aggressive is our disease. And if they're not always agreeing, then it really becomes subjective. And cancer, we presumably want a more objective way to decide how aggressive our cancer is. And so enter Prolaris. This is our biomarker test in the prostate cancer space. And it looks at cell cycle proliferation genes. So we know across several cancer types that cell cycle proliferation genes are important. We know that in breast cancer, colorectal cancer, pancreatic cancer, that all these types of cancers share these gene types, these cell cycle proliferation genes. And so on the left, you can see, where it says cancer, we have normal tissue that the cells are dividing at, normal rate and everything looks okay. And then cancer tissue, they start to divide at an abnormal rate. And so the checkpoint for the cell division get out of control. And then you see tumor behavior, somebody who has a low cell cycle proliferation gene expression might have a more indolent disease, meaning that their disease is just kind of hanging out, not acting aggressively. Whereas on the right-hand side, you have high CCP, so high cell cycle proliferation gene activity, and that cancer is going to behave more aggressively. But if we're not looking at the actual cell cycle proliferation genes within the individual tumor, we'll never know how it's really behaving. So Prolaris looks at these genes, combines it with the clinical and pathological features that I just mentioned, tumor stage, PSA, Gleason score, etc., and it determines the prostate cancer's true behavior. So how is that individual and their prostate cancer behaving? And a study by Jack Cusick found that cell cycle proliferation is 2 times more prognostic than PSA and Gleason score combined, meaning, and this is in the disease-specific mortality space. So essentially, it showed that running a Prolaris ends up being 2 times more prognostic to decide what that patient's disease-specific mortality is from prostate cancer than PSA and Gleason score combined can tell them. And then the other portion of our testing and what we know is important in prostate cancer patients is genetic mutations. So I'm sure many of you have heard of BRCA genes in the breast cancer space. We know that BRCA genes are also important in prostate cancer patients. And why is this? Well, study by Castro found that patients who have a BRCA mutation, who harbor a BRCA mutation, prostate cancer patients are 6 times more likely to die from prostate cancer within 5 years than their counterparts who do not carry a BRCA mutation. And they are 4 times more likely to develop metastasis within 5 years. So for instance, a guy who has favorable intermediate disease, no gene mutation, no BRCA mutation, we know he has roughly a 2.5% chance of dying from his disease within 10 years. We know that, within 5 years, we know that a guy with a BRCA mutation has an 18.5% chance of dying. So that's a stark difference. All right, and this talks about how Myriad can provide a better answer for every man with prostate cancer by individualizing the treatment of that patient and really analyzing their individual prostate cancer and how it's behaving. And so we know we can run Prolaris in biopsy tissue for any patient with low risk, favorable intermediate risk, unfavorable intermediate risk, and high risk disease. We know that germline mutations can be run in all patient types. There are some caveats for your low risk and favorable intermediate risk disease patients. We can delve into that at a later date, but anybody in the high risk metastatic space qualifies for genetic testing, germline testing. And then come January, we're actually going to start offering somatic mutation testing in our Precise Tumor test, which actually looks at the metastatic cancer tissue itself to see if the cancer tissue in the metastatic cancer tissue has a gene mutation as well, since we know all cancer is caused by mutations. And so we're looking for the mutations within the prostate cancer itself. All right, so as I've been talking about, this allows you to personalize patient care. And so we're not just grouping men into cohorts anymore, we're really treating them on the individual level. So Prolaris allows us to identify patients who might be candidates for active surveillance, whereas before they may not have been. They may have had the kitchen sink thrown at them and, they could have gotten ADT or radiation or surgery when really they may have been able to avoid that. If they had a Prolaris test, which would run the CCP genes on their tissue and let us inform their physician how aggressively their cancer is behaving. Germline status, so whether they do carry a BRCA mutation or another mutation, also gives patients opportunities to get drugs for patients who might harbor those mutations if they end up metastasizing. It also informs family members about that they might need to get tested because the family unit might harbor a mutation. It helps to inform about other primary cancers. So we know if you carry a gene mutation, you might also be more likely to develop pancreatic cancer, ovarian cancer in females, male breast cancer, higher risk for melanoma, et cetera. And then, as I mentioned before, the Precise Tumor looks at genes in the cancer tissue itself. If the patient were to progress to metastatic disease, and it might allow them treatment that they would not have gotten otherwise if they had not gotten the Precise Tumor run, also makes them eligible for clinical trials. So here's a case study. Here's a gentleman, he presents, his PSA is 4.8. He's favorable intermediate. He's got a 3+4 Gleason score, 7, less than 34% positive cores. His clinical stage is T1C. And so he might be thrown into this bucket of favorable intermediate risk disease and treated in X way. But what are his molecular test results? And what's his germline status? Because that might change how we treat this gentleman. And then this is just real quick to compare breast cancer and prostate cancer standard of care. So in breast cancer, when a patient presents, this is everything that they're offered: a clinical exam, mammography, grade of their cancer, what it looks like. They get hormone status. They get molecular markers, germline testing, MRI. On the right, you see prostate cancer. The only thing that's really missing is the hormone markers because they're just not relevant in the prostate cancer space. But otherwise, they're not that dissimilar when you look at what they're offered up front. All right, and so back to this gentleman. So his molecular test results, he comes back in the active surveillance bucket. Whereas before, if we hadn't gotten the Prolaris, he might have gotten single modality treatment. He might have lived in this area. He might have gotten active surveillance. But now we have a more objective way to say you can safely pursue active surveillance based on the genetic material that we've run on your specific prostate cancer. It's not behaving very aggressively. We would feel comfortable watching you.
Christina,
yes.
What's the probability of a false or a false test from Prolaris?
I mean, okay, so I mean, can you clarify your question a little bit?
Like a false classification or an improper classification from the Prolaris test.
So really, I mean, I don't know an exact answer to your question. I can get it for you. I mean, the only time that we would ever really have trouble is if we had like insufficient tissue and we couldn't run, because it's an RNA-based test. And so if we had insufficient tissue on the biopsy, we wouldn't be able to run the test.
Okay.
So that does happen sometimes. It's just insufficient and we can't run it. I don't know that we really have like a false positive. And Sophia, yeah, I don't know of an exact number, but I can get it for you.
I'm just curious. Okay.
Yeah, if we were. And then this guy, his germline results negative. So he does not harbor a germline mutation, which allows you to feel comfortable that, you know, he's not a mutation carrier that might blow up on you. So even though he looks low risk on, you know, this left side with his Prolaris, he may blow up on you if he has, you know, a germline mutation. So he might end up acting more aggressively. His cancer might act more aggressively than it would have otherwise. All right, so this is an example of a plan. So now that this guy can safely pursue active surveillance, he can get a PSA drawn every 6 months, a confirmatory surveillance biopsy at 1 year, just to make sure everything is stable. And then if everything is stable with his PSA, he can get a PSA every 6 months, continue to do that, and then get biopsies every 2 years. Say this man comes back and, oh my goodness, actually his cancer is behaving very aggressively and he needs multimodality treatment. So he needs radiation plus ADT, or he needs escalated surgery, intensified surgery, and he's got germline mutation. So, and he's BRCA positive. So this is going to change things, right? So this guy who presumably looked kind of like an average prostate cancer patient is now presenting as somebody who needs intensified therapy. And we have concern for other cancers, other primary cancers. And we have concern that if we do not treat this cancer very aggressively, that it could come back in a metastatic form because of the BRCA mutation and because of the aggressiveness of the cancer. Okay, again, this is kind of circling back. You know, this guy now has a BRCA mutation. So as I mentioned before, 6 times more likely to die from his prostate cancer, 4 times more likely to develop metastasis within 5 years. And we know that in general, compared to prostate cancer patients without a BRCA mutation, that men with BRCA mutations live approximately 7 years less on average. All right, so an active treatment plan example would be radiation with ADT, and then after completion of that treatment, PSA every 3 months for 1 year, then every 6 months thereafter. And should this gentleman have 2 PSA increases from nadir, we would assess for mets or recurrence. And if the patient does progress, we know that because we've gotten their germline mutation status or their genetic mutation status, that he would be eligible for drugs that are specifically indicated for patients who do have germline mutations and or clinical trials. And if we didn't know that he was a BRCA2 mutation carrier, we wouldn't know to offer this gentleman these targeted therapies and clinical trials.
Christina, can I ask a question real quick?
Sure.
So staying with this patient here,
Mhm.
what was it that made this patient aggressive? Was it the fact that he had a positive BRCA mutation, or was there something else in the Polaris test that indicated he was aggressive versus just, one that could go on active surveillance?
That's a great question. So think of these two things as separate. So the BRCA mutation did not cause this gentleman to, it may have caused the cancer. So let's, back up there. However, it didn't cause his Polaris test to fall in the multimodal treatment. The genetic material on the cancer itself was found to be very aggressive. And
Gotcha.
that is what caused, so this is a molecular score based on the genetic profile of the cancer itself. Whereas the germline test is actually a blood test, and it's a mutation that this gentleman inherited from either his mother or father. And it's on every cell in his body. Does that make sense?
Yeah, so a combination of those two things inform the treatment that
Correct.
this patient received, not just based solely off of the 4.2 or the 4.8 PSA
Sure.
score. Gotcha.
Correct. Yes. So they are separate and distinct tests, but they are complementary.
Gotcha.
Yeah.
Okay. Makes sense.
So, okay. So then here's, again, he's now case example 3, falling in the active surveillance bucket. And now he has, he's MSH6 positive. We know that this gene mutation doesn't have any indications for prostate cancer itself, but we know that it does have indications for colorectal cancer. So we know if a patient were to test positive for MSH6, we know that this puts them at increased risk for colorectal cancer as well. And so we would recommend increased screening for colorectal cancer. We would also recommend that family members get tested so that we can help them get access to screening earlier and more frequently as well. So you can see where getting the genetic test done, the germline test done, might not always be something that's going to inform prostate cancer treatment, but having the diagnosis of prostate cancer lends itself to access to genetic testing, and then it can inform us for other life-saving screening modalities as well. So.
It's great.
All right. What's that?
No, that's great. Thank you.
Okay. All right. And so, as I said before, we provide a management. Oh, I haven't said this actually. I'm sorry. We also provide a management tool. And so that's a great thing. I used to love, I didn't love if my patient had a germline mutation, but I would love the result that I would receive in the clinic because it was very layperson friendly. And so it was very accessible to the patient for them to read. And clearly it says, you've got this MSH6 mutation. This puts you at higher risk for colorectal cancer. We're recommending a colonoscopy, at 20 to 30 years of age or 2 to 10 years younger than the earliest diagnosis of colorectal cancer in the family. And we want this done every 1 to 2 years. So this allows the patient to understand what they're at risk for. It's red, it's highlighted, and what you need to do. In addition to that, we have genetic counselors who work in-house at Myriad, who, if a patient were to get one of these tests run with us, they get access to free genetic counseling. They can set up an appointment, whether it be online or via the phone, and the genetic counselor can go through every detail on the result and give the patient information for what they need to do moving forward, what kind of physician they need to go see, what they're at risk for, and they can help guide family members, what the family members need to do as well. All right, so back to this, or building upon the guy with the MSH6 mutation. Here's his active surveillance plan, because we know his prostate cancer is not behaving very aggressively, but now we know that he is at high risk for colorectal cancer. And so we know that we need to give him a referral to GI to go get his colonoscopy done, in addition to continuing to surveil his prostate cancer. All right, we also have, as I just mentioned, genetic specialists, and so they can go through everything about the report with the patient. And we also have what we call strategic account managers, and they're process specialists. So they can go into the VA systems and help the VA physicians and VA staff understand how to incorporate the testing into their protocols and procedures for their prostate cancer patients to make it easy on both the staff and the patients. So there's value in standardizing. There's value in standardizing anything, as we know, but it ensures that each patient is getting the same high quality of care. We know that it provides consistency, and we know it helps to adhere to guidelines, so NCCN guidelines, which are the driver of cancer care, and it improves efficiency if we have a protocol in place and we're doing it for every single patient. We get good at it, and we make sure that it's done in an efficient way. And as we like to say in urology, every man deserves a better answer than just being grouped into a cohort. And our history, as we say, is your patient's future. So we've got 30 years of genetic testing experience. We've tested 5 million patients, and we have the largest library, for lack of a better word, of mutations in BRCA variants. And so we're able to definitively classify more BRCA mutations than anyone else. Whether, that by that I mean we can tell you, the patient, whether the mutation is something that you need to be concerned about or something that is benign. And oops, I'm sorry. Myriad, so Medicare covers Prolaris at 100%. Actually, it covers all the tests at 100%. We know that greater than 93% of patients pay $0, and we have financial aid available. I know from my own personal experience as a clinician, we will never balance bill a patient, so we'll never run a patient's test were they to have some enormous out-of-pocket cost and then come back and say, oh, you owe us, $3,000. So we always would let a patient know that they have an out-of-pocket cost before we run their test. And any other questions?
Who typically prescribes this? The primary care, urologist, or oncologist?
So for a man with prostate cancer, it's urology. It's sometimes, if the urologist did not get it, then it would be a radiation oncologist should they get a consult or a referral to radiation oncology. But typically it's those two.
Okay.
Those two providers. Now, if they were to progress to metastatic disease, then this precise tumor that I talked about, where it analyzes the cancer tissue to see once they're metastatic, that could be a medical oncologist. It could also be a urologist if they manage their own metastatic patients.
And I take it you're on the federal supply schedule for the VA.
So I don't know I know that, like, are you referencing like TRICARE or? No,
inside
okay.
the VA medical center, VA medical process.
So I think, okay, so I actually had this conversation earlier. I think it's per system. So I think it just depends on which VA, like not the federal. I think it's state-based, maybe. I need to double check on that.
Okay. Well, we can maybe help you with that a little bit.
Yeah,
too.
I don't know the answer, because I know that like when we get tests from VA systems, it's like whatever contract is established within that VA system itself. Does that make sense?
Mm-hmm. Yeah. No, that's good. I appreciate that. Anybody else questions?
Yeah, I guess my question has to do more with the VA in that, is this a test that we can request, or is it our expectation that the urologist will go ahead and order it as part of their diagnosis?
Yeah, that's a good question, and I'm hoping that our next speaker can probably address that to some extent, but we'll see.
So
Okay.
so we've actually seen it. I mean, okay, so we have a ton of urologists who order this test, right? They believe in the utility. Sometimes they'll order in a subset of certain prostate cancer patient populations. So they may say, oh, we're going to order on our Gleason 6, 7, and 8 patients. We have some who see utility for all of their prostate cancer patients, and so they order on all of them. We have some urologists who say, I typically treat my favorable intermediate guys like this. This case is kind of stumping me. I'm not sure exactly how to treat this patient, so I'm going to go ahead and order a Prolaris. Sometimes we have patients who see us, have heard about us, and they go and request the test through their urologist, and then the urologist orders it. So I've seen it from both perspectives. So it kind of just depends, but there are many times where we have seen patients advocate for themselves and say, I want this test run. I want to confirm that I'm getting the treatment that, the Prolaris is going to tell me that I need. So I hope that answers that question.
That's good.
Christina, do you know how long ago you started to provide the counseling with the patient? Because I had the Prolaris done about 4 or 5 years ago, and I did not have interaction with Myriad.
Sure. So Prolaris, the genetic counseling is for the germline testing, like the BRCA mutation testing.
Okay.
So it's for the other, that's for the blood test. So that's for the hereditary cancer. It can get a little cloudy. That is for the blood test to see if you carry something in your genetic material in your DNA that caused the cancer that you inherited from your mother or father. That's different from the Prolaris test, which is just run on the prostate cancer tissue.
That's what I was verifying, because I had the germline I had was in vitae.
Got it. Okay. Yep. So Prolaris, there's no genetic counselor for that. It's for just the germline.
I get the report though. You get the report that gives you all the layout anyway.
Yes.
Well, that's great. I think any other questions? I don't see any. Christina, thank you so much for your time, and we appreciate the insight into this thing. I know that we're all trying to get more and more involved in the whole DNA sequencing, and that's why Dr. Rettig is going to speak to us here next. But part of that is we're still hearing around the VA and with our VA constituents that it's sometimes hard to convince the other doctors to actually do it or to get into these tests. So it's good that we have some information about Myriad. We'll get some more from you, and it's we'll just try to push it out to both patients and physicians around the system to start using it or ordering it if it's in its appropriate state.
Most definitely.
Yeah, and then
Let me mute real quick.
Sorry, we're in the same room. Sorry, I was just going to add that we have patient and provider brochures that we have available that we can share with anyone on this call who has interest, or we could pass it along to further providers as well.
Yeah, that's great, Sophia. We'll get some of those. We'll order some of those for next year as we start rolling out some of our support group type of functions and things.
Perfect. Thank you all.
Okay, thank you. Thanks, everybody. Stay warm in the snow there.
Okay. Thank you for having me.
Okay.
Y'all take care.
Thanks. Everybody, I don't think I have to introduce Dr. Rettig. Matt, you can take the show. I think everybody knows you, and a lot of us have met you before, but really the big issue for us is, and you can address this, is we're still not seeing 100% uptake or a recommendation for guys to do DNA sequencing or screening when they get diagnosed across the VA. And I don't know how we're going to change that, but we just keep talking about it and keep trying to push these guys. So, but anyway, over to you. You can.
Yeah. So let me just clarify something with respect to the prior presentation. So the testing that Myriad does is generally for patients with localized prostate cancer to help better risk stratify them. So you know about the low, intermediate, high risk, or even intermediate. There's favorable and unfavorable, intermediate, and low. It's very low and low. And clearly, those tests, such as Myriad's, and there are other molecular tests that are done to help further refine an individual patient's risk. Those are not currently being universally allowed by pathology department. So to be very specific, we want to order them all the time. And the director of pathology for our VISN, John Vallone, refuses to do that. So it's insane, it's unacceptable, and anything that you can do to try to make this happen, it should be something that any veteran who has prostate cancer should have access to, and there shouldn't be some individual in a pathology department who says, well, I'm not doing it. It's not in my budget or something like that. I don't want to pay for it. Just some sort of arbitrary decision. So I'll throw that out to you. It might not sound good, but I think this is a good forum to mention that.
Yeah.
So
we'll take that on. What's his rationale? He just doesn't like it, or he doesn't like Myriad, or he doesn't believe in it?
I don't really understand it. He's not. He's a challenge to work with. He used to be the chair of the pathology department, and he was promoted to the director of pathology for our VISN, and it is beyond frustrating. In any event, let me sort of start my talk, and really what I strive to do here is to sort of give you an overview of genetic sequencing and sort of demystify some of these concepts and describe how we do it, who we do it on, why we do it, and how these results are used in oncology. As a medical oncologist, I largely, not completely, focus on patients with advanced disease. The assay that Myriad was just discussing is really for localized prostate cancer that helps further risk stratify and predict outcomes, whether the patient will have a PSA recurrence or the cancer will metastasize, et cetera. Really what I'm talking about now, and those tests that Myriad does and other companies like Decipher or Polaris, these risk stratification tools are usually focused on RNA. In other words, the genes that are expressed, and they have usually a panel of different RNA transcripts that are tested, somewhere from 10 to 20 or 30 markers. And she mentioned a panel of proliferative markers that are used, but different companies use different ones. What I'm talking about now will be genetic sequencing, looking at the specific genetic code of individual genes. And so let's get started. So when talking about precision oncology, really what we're talking about is identifying something specific to a patient that will help manage that patient. Commonly, and what we're focusing right now is DNA sequencing and using DNA sequencing to guide therapy. And I'm showing you here is 3 broad categories of how genetic sequencing can be implemented in a patient with prostate cancer. The first is
Can
standard.
you share? Hey, can you share your screen?
Oh, I'm sorry. Yeah, give me a sec here. You see that?
Yep, great,
Okay.
thank you.
So the first, what you can see is when we do sequencing in about 25% of patients, we can identify a genetic mutation that can be paired with a specific treatment that already has FDA approval based upon that mutation. You heard about the BRCA genes, and we have this class of drugs called PARP inhibitors that are FDA approved for patients with prostate cancer who harbor one of these mutations. Second category is the off-label use of an FDA-approved drug. In other words, there's an FDA-approved drug that's been approved for some indication, but we have evidence that that drug may be effective in a patient who happens to have a specific mutation. An example of that would be, we'll go back to BRCA genes. Those mutations in those genes tend to be very sensitive to a very well-tolerated form of chemotherapy called carboplatin. And then the third category are clinical trials, where we're trying to discover therapies that are effective for specific mutations. And we have a lot of clinical trials within the VA prostate cancer network aimed at biomarker-based clinical trials. Okay, so, and let's see here. So you've sort of probably seen some of these data. I won't belabor it, but prostate cancer is the most commonly diagnosed malignancy amongst veterans. It's the #1 cause of death amongst non-smoking veterans. If we include all veterans, lung cancer is the #1 killer. And the incidence keeps going up and up, as is the mortality, overall mortality. So let me sort of demystify this concept between germline and somatic mutations. So germline refers to germ cells. We're talking about either a sperm or an egg, whereas a somatic mutation arises in a cell in a post-fertilized state, usually in a human being after birth, usually later on in life. But there are some mutations that can occur after the egg is fertilized, while the infant or while the baby is developing in utero. And we see that in testicular cancer, and that's probably why testicular cancer tends to occur so early in life. It's the most common cause of cancer in men aged 20 to 40. So here's a pictorial that distinguishes between germline and somatic sequencing. On the left is germline, and you see a sperm and you see an egg. The red indicates a mutation in a gene, we're not defining which gene it is present in the sperm. So when the sperm fertilizes the egg, the embryo and all cells that arise from that fertilized egg will consequently harbor that mutation. So that in someone who has a germline mutation, it's every cell in the body that will have that mutation. And when that individual, in this case, a male, produces sperm, 50% of the sperm will carry the mutation, and therefore any individual offspring of that carrier will carry that gene. So it's a 50% chance of passing it on to any individual. Conversely, on the right are somatic mutations. These are acquired mutations during life, and they will only occur in the mutation in the cell and its daughter cells that the mutation arose in. And the overwhelming majority of mutations that we see in cancers are somatic. Only about 5 to 10% of cancers are driven by germline mutations. So germline mutations are hereditary. They're present at birth. They're present in all cells, including the normal and the cancer cell. The mutation is originally present in the sperm cell, the oocyte, and it can be detected by sequencing non-cancer DNA, blood or saliva, and that's those are the tests, the sources of normal DNA that are used. They're typified by early onset of cancer. So patients who have a germline mutation, they tend to develop years before than a patient who has a somatic mutation. And as I said, it represents about 5 to 10% of all cancers. And this pattern of inheritance is autosomal dominance, which basically just means that half of the offspring of an affected individual will inherit the mutation and be at risk for developing the cancers that are associated with that mutation. Somatic mutations are not hereditary. They're present only in the affected cell type or tissue. They're detected by sequencing the tumor DNA. The tumor DNA itself can come from a biopsy, from a surgical specimen, or the tumor DNA that's in the plasma. And that's different than a blood sample that's used for the germline mutation. When we use blood for the germline mutation, we're looking at the cells. That's different. Here, with somatic mutations, we're looking at the DNA that's shed by the cancer into the bloodstream and floats as naked DNA in the plasma. That's what we call circulating tumor DNA or ctDNA. And that's another source of tumor DNA that can be used for sequencing. And as I mentioned, only a small percentage of cancers are driven by germline or hereditary syndromes. 90% of all cancers are driven by somatic mutations only, and they have a later onset. So when you classify cancers, you can kind of think of them broadly in 3 categories. First is the most common, just a patient walking along and gets prostate cancer at age 66. Those are called sporadic. There's no familial history of cancer, and the patient, for whatever reason, develops prostate cancer. Then there's the hereditary syndromes, where there's a specific gene that's detected as having been mutated and is not functional in the normal DNA. So here we do take a saliva sample or a blood sample and look at the blood cells and do sequencing and say, for example, we see a BRCA2 mutation in that patient's normal DNA, and that puts a female predominantly at risk for breast and ovarian cancer, but other cancers as well, many other cancers, and and in men, they're at risk for pancreas and prostate cancer, male breast cancer, many other cancers. And then there's this other category for familial, where we don't have a specific genetic mutation, but there's a clustering of cancer cases in a family, and that could be due to multiple genes that work together to contribute to the cancer, as well as shared environmental exposures. And that's just going into some more detail about what I just said. Won't belabor that. So the hereditary cancer genes are listed in this table here. And you see here the BRCA1, BRCA2, several other genes. And what you can see in terms of their function, which is in the far right column, is that almost all of these genes are involved in repair of DNA. One of them is involved in regulating the male hormone receptor, it's called the androgen receptor, and this gene represses the function of the androgen receptor. So when there's a mutation in this gene, there's overactivity of the androgen receptor that can drive the development of prostate cancer. And this is just a further breakdown of some of the germline mutations in a pie chart, with BRCA2 being the most common hereditary cancer gene in prostate cancer. And we heard earlier that patients with BRCA2 mutations have more aggressive disease. And it's important to note that patients who have a hereditary cancer syndrome may not give you a family history. That can be because they may not know it. it could be because there's incomplete penetrance, which means that there are family members who may have the hereditary cancer gene, but just didn't, for whatever reason, develop a cancer. And germline mutations are present in about 12%, so 1 in 8 men with metastatic prostate cancer, independent, that's all comers, independent of family history, and about 5% of patients with localized disease. So why would you do germline testing? One, it can impact on screening decisions for cancers, a whole host of cancers, depending upon which mutation it is. If a patient is identified with a mutation, then family members can be offered the test. That's called cascade testing. And there's a potential to screen and prevent other at-risk cancers in the patient or in the family. So a female who has BRCA mutation can undergo earlier preventive earlier screening for breast cancer. They can undergo preventive treatments such as mastectomies, removal of the ovaries, oophorectomies. So there's a whole host of things that can be done. In colon cancer, earlier screening of colon cancer, you heard in the last talk. And then for the patient, you also can identify actionable genes. I mentioned that there are genes that when they're mutated, you can pair with a specific therapy. So those are the reasons why we would do it and who gets it. So essentially, what we really do now is anyone with metastatic disease, something called very high risk or regional metastasis, and then patients with localized prostate cancer who have family histories or have a particular pathologic appearance of their prostate cancer called intraductal or cribiform, a particular pattern that's closely associated with BRCA mutations. So how do we do the testing? We use some normal source, a source of normal DNA, saliva, blood, a buccal smear. To emphasize again, with blood, when we're looking at the germline mutation, we're looking at the cells, not the circulating DNA in the plasma. There's a lot of commercial panels that are available and that are routinely done at the VA. The local pathology departments do not pay for the test. It's covered by a separate pot of money. So there's no disincentive for the pathology department to prevent us from doing it. And they include usually a panel of genes. We use a company called Invitae. So let's switch to somatic mutations. This is a chart showing some of the most common somatic mutations that were seen in patients with metastatic prostate cancer. And in this study, essentially about 300 men who had metastatic castration-resistant prostate cancer, so really the lethal form of the disease, had a biopsy of a metastasis and underwent genetic sequencing. And each column represents a different patient. Each row represents a different gene. And if you just look at the top row, it says A or androreceptor. And you can see that the androreceptor has the most colored boxes filled in, meaning that it is the most frequently mutated gene in all of prostate cancer. The different colors indicate different types of mutations. The androreceptor, I like to say, ironically, is located on the X chromosome, which is so 2 X's is a female. So in an adult male, there's only 1 copy of the androreceptor. We said why we talked about why we would do germline testing. This is why we would do somatic testing. It's largely to identify the 25% of patients who have actionable mutations. And this is just a list of some of the mutations and treatments that can be applied to a patient with prostate cancer. Importantly, these therapies are not ordinarily used for patients with prostate cancer. They're really only used in patients who have the specific mutations that are listed here. So who gets it? Really, any patient with metastatic prostate cancer. It doesn't have to be castration resistant. We give we do sequencing on all patients with metastatic disease. Some patients with localized disease in select cases. The VA, you can order a sequencing on any patient with any metastatic malignancy. With localized disease, you may have to get pre-approval from the National the National Oncology Office, which is pretty easy to do. So how do we do the testing? The most preferred source of DNA is a biopsy or a surgical specimen, so some tissue. We prefer to have a metastatic lesion as opposed to looking at the prostate, because it's possible that the metastatic lesion has mutations that the tumor in the prostate doesn't. And it's preferred to have tissue as opposed to use the plasma, the circulating tumor DNA, because there's the tumor tissue genetic panels are larger, and there are some tests that can be very difficult to run on circulating tumor DNA. But it is a backup if tissue is not available or it's too old. And there are lots of vendors, including Myriad. The VA has a national contract with Foundation, and also more recently with Tempest. Both of those can be used. Excuse me, I have a dog that's barking here. So take-home messages for you, I guess, not the busy urology practice. So consider germline testing really for a whole range of patients, especially if they have very high risk disease or metastatic disease, or there's a family history. That will include pre-test counseling, which means that patients are counseled about the implications of the test result. And if there is an abnormality, or frankly, if there's not an abnormality, there's post-test counseling as well. And there can be genetic counselors that do that, and some of the vendors will provide that service as part of their costs. Somatic testing should be done on all prostate cancer patients with metastatic disease. So I'm going to give you a couple of examples. These are real life examples of using genetic sequencing to match the patient with a therapy. And I said there were 3 pathways that can go down: standard of care, where the mutation is matched with an FDA-approved therapy for that mutation. There's also off-label use of FDA-approved drugs, and then there are clinical trials. So this is an example of a patient who had hormone therapy, whose PSA was climbing. The hormone therapy is denoted as ADT, androgen deprivation therapy. Patient got radiation, God bless you, more hormone therapies, and the PSA continued to go up, and a biopsy of the neck mass revealed this mutation in a gene called MLH1. Patients who have MLH1 mutations inactivates that gene, and that results in tumors carrying many, many more mutations than they normally do. They have what's called a hypermutated phenotype, and that type of tumor is susceptible to these checkpoint inhibitors. This one here, pembrolizumab or Keytruda, is approved for these mutations. Essentially, what happens when a tumor has lots of mutations is the immune system recognizes the tumor as foreign because it expresses all these proteins that are different than normal proteins. So the immune system is able to recognize the tumor as foreign. However, the tumor elaborates mechanisms to prevent the immune system from killing it. And that's where the pembrolizumab comes in. It disinhibits, it overcomes that inhibitory effect of the tumor on the immune system and allows the immune system to be unleashed to attack it. So it can be a very effective therapy. And these immune therapies, when they do work, can elicit very, very durable remissions. So here's here's an example of a off-label use of an FDA-approved drug. Here's a patient who had ADT, bicalutamide, abiraterone, progressed on this, developed liver metastasis, and underwent a biopsy. At the time, PARP inhibitors were not available, and the patient had a BRCA2 mutation, and the patient received carboplatin. And you can see that the patient had just a profound drop in his PSA, and the patient today, 4 years later, continues to maintain an undetectable PSA. He gets the chemotherapy intermittently. This is a real example of an extreme response for a patient who would have normally succumbed to his disease years ago, but has full quality of life as a consequence of this next generation sequencing. But as I said, only 25% of patients have a mutation that can be paired with therapies. And a main goal or a major goal of our prostate cancer network is to identify therapies that cover a much greater percentage. We want a patient for a drug for every patient, so that we want to cover mutations more effectively and expand that 25%, ultimately, ideally, to 100%. So that brings us to our biomarker clinical trials. So here is depicted on the left are patients with advanced prostate cancer. The patient undergoes tumor sequencing and germline sequencing, and we see that different patients have different mutations, and we select the patients who have, let's say, the mutations in blue for a PARP inhibitor study, and the patients who have a red mutation will go onto a different study with an immunotherapy. So this is how these biomarker driven studies are done. There are some mutations that occur quite frequently in prostate cancer that are not typically found in hereditary syndromes in prostate cancer. Most of these mutations are acquired or somatic, and they're genes called P53 or P10, PTEN, that can be seen in 50% or more of patients with metastatic prostate cancer. And we have some studies that are targeting these mutations, but ultimately we need better drugs to test them. And then this is just further information about how we select patients for clinical trials. So I'll stop there and open the floor for questions.
Dr. Rettig, that was one question I had. Earlier, you mentioned something about in the somatic testing that the tissue was too old. What's considered too old?
There's no absolute cutoff, but typically when we have tissue that is 5 or more years older, I think we're starting it becomes less likely that the DNA, that there'll be adequate amount and quality of DNA for sequencing. Now, we send the samples anyhow, but they'll typically be called as QNS, quality or quantity not sufficient, either from the local pathology department, or if it goes from the pathology department to the sequencing company, when they try to extract the DNA, they'll just say they'll give us the QNS report, quality not sufficient. So that is a problem. There's another problem with prostate cancer. It's so when we have let's say we have a biopsy and the core sample says 50% of the core biopsy is prostate cancer. The problem is that in that 50% that harbors cancer cells, there's still a lot of non-cancer cells in that 50%. So it's 50% of the specimen harbors cancer cells, but the percentage of cancer cells that are in that 50% may be kind of low, and that's just an inherent issue with prostate cancer. There's a lot of non-cancer cells in there, stromal cells, inflammatory cells, fibroblasts, et cetera, that are present in the specimen that are not cancer cells. So the cancer cells are diluted by non-cancer cells, even in the part of a biopsy or a surgical specimen that has cancer in it.
So the other part of the question I had was for a patient who's been metastatic for a while and has been on some of these other therapies, ADT, and some of the further therapies down the line, and they had not been genetically tested, can they still receive genetic testing?
100%.
Okay.
You get genetic test, yeah. So if they have metastatic disease, they should. In fact, that's the patient you should definitely be doing it on. The drugs that we have that have FDA approved that were, or even the off-label use of drugs, really currently for the advanced stage of patients, the metastatic patients, we are testing them earlier and earlier.
Mhm.
So that's sort of the typical drug development scheme, is tested in the most advanced stage of the disease when there are fewer choices for patients. So the FDA is willing to test a drug of uncertain benefit on a patient who doesn't have many other options, as opposed to a patient who has localized prostate cancer, whose life is not immediately threatened. They're less likely to take a risk on a drug. In addition, the drug companies want to get an answer and bring a drug to market. And when overall survival is the sort of gold standard for FDA approval, really it would take decades sometimes if you do controlled trials on patients with localized disease. So that's why the initial studies tend to be in patients with later stage disease.
Thanks.
Hey, Matt, on when we talk to guys out there, when we talk to the to vets that are patients and things, and we're hearing it, still hearing it quite a bit, that when they're in with the urologist or even some oncologists, they don't want to push for the DNA sequencing. What is it that we need to tell these guys, or what is your recommendation? Is it, have them call you or get into your program or your study, or what do we do?
There's a couple of things going on. Okay, so first of all, from the National Oncology Office, there's now it's part of the prostate cancer clinical pathway, and physicians, as part of their evaluations, are being their performance is being gauged based upon adhering to the pathway. Okay, so that's one. Whether or not that has any teeth, any downstream consequences if somebody doesn't adhere is a different question, and I don't have the answer to that. One of the programs that I developed at RVA was one to overcome this issue, and that was the NACHO program, which is what's called the Next Generation Sequencing Ascertainment for Choice of Oncology Therapy. What I was trying, since I have a database of every veteran that's ever had prostate cancer, so and in that database, it's immediately searchable. It has about 300 different searchable factors, including their pathology, what the pathology specimen number is, where it is. And so as part of that program, we were trying to just bring in samples from everywhere in the country to have it sequenced at our VA, and then to report the results back on the ground to the provider. We have had a lot of trouble just getting pathology departments to send us slides. We'll do, literally, Mike, literally. This program has been in place for 2 years. It is that difficult to get pathology departments to do that. So it is a challenge. We do have some individual pathology departments that have been willing to play ball, but it's not easy. So we have a GU pathologist who's willing to go through those slides or tissue blocks, and we have technicians that are paid for it that can set up the specimens to be sent out for the sequencing. We'll get it done, we'll get the report, and we'll not only upload it into the chart, but also send message and letter to the providers.
So, okay, so I mean, we can ask, I mean, if we get the Army engaged, why can't, I mean, as a patient, why can't we just keep asking them to have it done, right? Or send it to you?
Should.
Doesn't
I mean,
cost them anything, right?
Doesn't, it just, you know, no, it doesn't cost them anything. And but it takes a little effort, just a little effort to pull the slides off a shelf, right? It does take some effort, does require someone to do that. And if they don't do it, so they said, whatever, I'll do it. I don't want to send it out. These are my slides, but I'm not sending them out. So that's what ends up happening.
Okay. Well, all right, let us think about it. We'll come up with some ideas of how to shame them into doing it or something. I don't know.
Yeah, so I've talked to the National
met
Director
this
of
guy.
Pathology, and I
That's
tried to
Dr.
get, what's
Yeah.
that?
He's like a patient advocate.
I've seen him before. Somewhere.
Yeah, it's inexcusable that it's not done on any patient, on every patient.
Yeah.
And we've tried to work through pathology, Wang Rodriguez, the head of pathology nationally, but we can't get any traction. Where, you know, how about sending a letter to every chief of pathology telling them this is mandated? If there's a request, you do it. I mean, so it's very hard for us on the grounds to put pressure on a pathology department somewhere else. There's
Well,
no teeth in our request. But if they
Well,
have
that's-
pressure from
but that's,
above,
I think, maybe we can help. I mean, maybe if we engage and we know, and we'll get with you, we'll follow up with you to get exactly what needs to be said, or what, if we walk into our offices or our different VAs, that's what we're supposed to do. We want to go into our other VAs and engage them and have them participate in this program, right? And if it's for the benefit of the patient, then let us ask for it. Let us push it
Okay.
out there. Who do they contact? You or who's their?
Well, bottom line is, we know who the patients are that need to be sequenced. That's not the issue. The question is getting pathology departments, wherever, Biloxi, Mississippi, wherever it is, to send us the specimens. That's it. So I don't think that quite frankly, I don't think the carrot is working. I think a stick may be required.
Yeah. Right.
But yeah.
Well, we can try to we can go find some sticks or whatever and start talking about it. I mean, this is silliness that you're almost, it's another disparity in care.
Yeah, it is a disparity, and you know, you're absolutely right. There are two ways of trying to make something happen, and that's one from the doctor side, but having patients do it is another way of doing it, and pressure from both sides. And then the third arm of that would be maybe pressure from, you know, the most senior levels of the VA. This is said basically, yeah, this should happen. So if the congressman tells the secretary, this is not acceptable, and the secretary can make it happen. I mean, literally, probably with a stroke of a pen.
Okay. Well, we can. Okay. Point taken.
Yeah.
All right. Where is this a research program who's it funded by? Is it Rachel or
Nacho is a clinical, that program is a clinical operations program. There's no research associated with it. It is funded by Rachel, even though that's a research source. So she has been kind enough to fund that with research dollars for clinical operation. This is all clinical care. There's no research that's associated with us sending the sequencing out for patients. We're just doing this as a service for veterans.
So would it be prudent to take the information about Nacho, what Nacho is, and do a letter writing campaign to our congressman
Yeah,
to
happy
get them behind it?
I would
Because
love to see that.
I could see a need to have the constituents talk to these congressmen about this program that exists, that addresses a disparity in the VA system that can be overcome if they can get the VAs to send the slides.
Hey, Matt, is this going to have an effect on, I mean, are you guys doing this for all other cancers too, not just prostate?
So the Nacho program is just for prostate cancer. That's what I can do. But the sequencing will be covered for any cancer. That this pot of money that comes from the National Oncology Office is for any cancer. There are some cancers like lung cancer where certain centers like ours have in-house sequencing specifically, so we don't send it out and it gets done automatically on the patients. But mostly, so it covers a wide range of cancers. It's not restricted to prostate, but the Nacho program is my program specifically for prostate cancer.
And Tony, we can take on prostate for sure. And I think that let's, Matt, if you can send me your whatever overview on Nacho, we'll put together some letters for it. The other, I mean, if you've got is there a program summary or an abstract or something like that?
Yes.
Okay. But what I was also thinking, Tony, now that the PACT Act has passed and they're doing all these, everybody's got their own registry that they're trying to get you to register for, right? So the PACT Act, we can take this to the TEAM coalition, the toxic exposure for military servicemen guys, and we'll get them to help write the letters. We'll get the letters passed out. They're the guys that have 36 VSOs, about 25 million members total. And so Matt, give us the Nacho stuff. We'll draft a letter for you to make sure that we're not saying things too loudly or too out of whack, but we'll give it to you, let you review it, and we'll send it out in the new Congress. When they get installed, we'll send it to everybody. It'll be on their desk when they get there.
Sounds good to me.
And that's how we get the VA. That's how you get the secretary to pay attention, right? And we'll talk to Neil Dunn as well and make sure that he pushes it as well.
Mike, I'd appreciate getting a copy of that information too, since I'm trying to get this other group formulated. I think that would be beneficial as well.
Yeah, absolutely. No, we'll all get it. We'll all share it here, Joe. And, I think we get your guys up to speed as well. I mean, you've got a good outreach. We've got another one too. We're teaming up with some guys in Texas that got 70,000 database of vets out there. So yeah, we'll get this done. I mean, and Matt, we'll get them all to start putting pressure on this thing. And I just can't understand what these pathologists, I don't know what the hell their problem is.
Yeah, I have no idea either. We're just trying to help and they push back. It's been a real challenge.
That's amazing. They just don't give you they just don't want to give up their data or their information.
So we actually went so far as we sent out a survey, and we did it twice because there wasn't enough answers. We surveyed every chief of pathology and the chiefs of hematology oncology to gain insight into why they're not doing it. We got a variety of answers, largely don't have the time or the bandwidth, that kind of thing.
It's just putting it in a package. It's just
some of it, yeah. Some of it was we don't know how to send it out. We don't know what to do. There was a range of explanations. We actually did a national survey.
Yeah, we're all too busy. Yeah, right.
Yeah, right. Yeah, except for the guy that needs it done and needs to get the testing done. So anyway, yeah. All right. No, that's good. Any other questions for Dr. Rettig?
I have a quick one
Joe.
because I heard the comment and I want to make sure I heard it right. You were saying that genomic testing is very difficult to get done, like the Polaris and the oncotypes.
Yeah, so what I talked about in my talk was just gene sequencing. What Myriad, Polaris, Decipher is those are panels for patients with localized disease that right and yes, we literally cannot do it. We have said that we have been told by our Vision pathology director, you cannot do this.
That's.
But you guys
something to-
want it done. Everybody wants it done. It's how you
Oh,
do, it's
yeah.
how you do active surveillance, right?
Of course, of course. So Mike, I don't order this as an oncologist. I don't order those. Those are for localized prostate cancer. Before I talked to you today, I double checked with our urologists, and Isla Garrett said, no, we still cannot do it.
When
So
you say
there's an
vision,
absolute-
what is
you're
that?
saying
Is
that there's a, go ahead, Tony.
He said vision, direct to vision. What
Yeah,
is that?
the way the pathology organizational structure is that there's a chief of pathology at each medical center. And then there's a chief that for each visit. And that's who I was talking about, was the chief of our visit, our group of VA medical centers in Southern California, and in Southwest US. He has said this will not be done. He also said that before he was the vision director, when he was our local pathology chief. So we are unable to order those tests on any veteran with prostate cancer. It is not left up to the decision
What's his-
of the urologist or radiation oncologist.
What's his rationale for that? For not ordering it?
Probably bottom line money, and
Yeah,
I think, yeah, I don't want to say too much about him, but let's say this is not the only issue that has.
You can negotiate with these companies to, to get a good rate. So it's not
Yeah,
like-
the number of tests that the VA would order is absolutely off the charts. And so they
For
should
sure.
have the best
Yeah.
negotiating power of any company out there.
yeah, and you don't have to pay $3,000 a test, which is the
Yeah.
official price, but or 3 to 4. But that's
Listen,
that's
it should
sad.
be done. Money shouldn't be the factor. It should be done. The
You
grand
got
scheme of the
Yeah, we got
federal
an
budget-
$80 billion budget. Come on. And the other part is, Matt, have you guys looked at, and maybe I should get to talk to Isla about it, is that why, maybe we can go around the system, around these pathologists in the meantime, and use community care network for this.
Yeah, that can be done, because once you refer a patient to the community, they
Yeah.
basically have a blank check. The problem with the community is the care can sometimes be less than ideal, and there's not a lot of continuity.
I get that. And I mean, we've been working with Julie Flynn, who's running a program. She's down in San Antonio, and that's some big issues that we're trying to take on her to help out with. But one of them is, I talked to her about not outsourcing any care, but just outsourcing a test,
Yeah.
like directly to Tempest, right? Because we're looking at the aviator study.
Yeah.
She says, yeah, no problem. Because Tempest has the big issue was they have to have a physician on staff that can order the test. Like you can't, apparently you can't, if you refer them to the community care, you would be referring them to a physician on staff at Tempest or on staff at Myriad. That guy would actually, and we're looking at signing up Tempest in the community care network.
I see.
So that, say if you wanted to get a test from whole genome sequencing, you would just refer the guy community care network to the doctor in
Yeah.
Tempest.
That's an
He would do it
interesting
and send
solution,
you the data back.
Yeah, that's an interesting solution. Yeah.
So if you want to, I'll talk to, I'll send you and Isla a note, because I think that we can do this. I think Julie wants us to push on this to get some patients and actually outsource these testing to these people. Like we can ask, Polaris or ask Myriad, who's their physician on staff. They're going to have a physician with an NMI number and all that kind of stuff.
Yeah.
So we just got to find out who that guy is and send in the referral. We have to get the company signed up in the community care network. They've got to be in with TriWest and with Optum.
Yeah, and
But-
the best thing is for there to be a national contract with the company, and then we can do these community referrals to the physician in the company, if that's possible. That would be
Yeah.
a neat solution.
Well, we talked about it when I was at Astro, and she's all over it. She was like, well, why don't you find some guys that want to try this and we'll work with you to get it done.
Yeah.
Okay. So we'll all get together and come up with those, the solution for that, because I can't see that this is, that, I mean, that shouldn't be deprived or restricted from having these testings done because some pathologist doesn't want to do it.
Right. Yeah, exactly.
It's valuable information to be used by the
It
oncologist.
frequently changes management.
Absolutely.
Yeah.
Absolutely.
All right, well, so we've got a mission. Let us think, we'll come up with a plan, Matt, and then we'll brief you on the plan and keep you in the loop, because we're gonna need somebody on your side to prescribe it out or whatever, to
Yeah.
prescribe these guys to the companies.
Yeah,
Okay,
understood.
do you want us to use, I don't want to pick too many companies. Do you want us to pick Tempus? We've got a really good
Well,
relationship.
I don't know that Tempus does this, the assay on
No.
localized prostate cancer. The assay, I think what we would prefer is one called Decipher. So there's Decipher, Myriad, Polaris, there's a whole range of them. They're all
Yeah.
listed in NCCN. Yeah, there's
Okay.
Archetype, but basically I think Decipher is the one that we think is probably the most robust, that we're most comfortable with.
Okay,
Yeah, it's covered under Medicare.
Yep.
So it's like
yeah.
routine.
Yep.
And what if a guy, Matt, have you got any guys that you've told that are inside the VA to go out, use their Medicare and get the test and bring it back to you?
I personally know, because I don't see.
Well, I know
patients
you're
on
not doing it,
stage,
but I mean, does the
I
urology do
I
it?
suspect not. Because once you send the patient out, you can't send them out specifically for that test. That's not how the community care works. I think you have to send them out to a urologist and they may take over care. So I think we haven't, I don't think that happens.
Okay,
Yeah.
all right. Well, you know, our big spiel to these urologists, and I talked to Lugpa and some other people, is that they're not to be taking over care. They're to be doing a procedure and sending it back to the VA.
Yeah.
And so I think we talked to Evan Goldfisher. He wants us to help educate the LUGPA groups on that whole thing. So anyway, we'll be in touch. We'll work on this, but this is a mission that we can, I think, let us do some investigation and we'll get back to you on where we're going to go with it. Okay.
Yeah, sounds good.
Okay.
All right.
Anybody else, any questions? Thanks for everybody for attending. Thanks for showing up. Hope everybody has a Merry Christmas and a Happy New Year. And we will be in touch early in the year. Stay tuned. I know we'll all talk in the next couple of days and get things going. But yeah, good to see everybody. Thanks again, Matt.
All right, you got it. Take care,
we'll be
everybody.
in
Happy
touch.
holidays. Yeah.
Okay.